Hey USAFP, this is Captain Emily Buck from the Madigan Family Medicine Residency. Today we will be discussing repeat oral glucose tolerance testing in late pregnancy via a case review. I have no disclosures. Gestational diabetes mellitus, or GDM, complicates 6% of American pregnancies. Screening is recommended between 24 and 28 weeks with oral glucose tolerance testing. Accurate and timely diagnosis is key to decrease the risk of perinatal and lifetime complications. No guidelines currently exist regarding repeat tolerance testing for women who develop signs of glucose intolerance later in pregnancy. Presented as a patient with signs of glucose intolerance after negative screening who underwent repeat tolerance testing in late pregnancy and was diagnosed with GDM. Our case concerns a 21-year-old active-duty Black prima gravida whose pregnancy was complicated by elevated BMI and excessive weight gain. Her initial GDM screening via 1-hour glucose tolerance test at 27 weeks was negative. She presented at 33 weeks for 2 days of abdominal cramping and 2 weeks of progressive polyuria. Her physical exam was unremarkable. Urinalysis was negative for infectious markers, though incidentally showed profound glucosuria that was not previously present. Due to maternal risk factors of high-risk race, obesity, and excessive weight gain, with new glucosuria, a 1-hour glucose tolerance test was repeated at 33 weeks, revealing hyperglycemia. Subsequent 3-hour testing was diagnostic for GDM. Home glucose monitoring and dietary management were initiated. Glycemic control was adequate throughout the remainder of her pregnancy, and she underwent induction of labor at 39 weeks with delivery of a healthy, average for gestational age male infant. GDM is defined as glucose intolerance developing during pregnancy. Risk factors include pre-pregnancy obesity, hypertension, advancing age, and high-risk race or ethnicity. The perinatal, maternal, and fetal sequelae of GDM include increased risk of hypertensive disorders, cesarean delivery, macrosomia, stillbirth, shoulder dystocia, neonatal hypoglycemia, and lifetime development of overt type 2 diabetes. The prevalence of GDM is directly proportional to that of type 2 diabetes within a population, with increased rates among Black, Hispanic, Native American, Asian, and Pacific Islander women. Prevalence is also impacted by the screening approach and diagnostic criteria utilized within a particular healthcare system. The ACOG recommends universal screening for GDM between 24 and 28 weeks with a 1-hour 50-gram glucose tolerance test followed by a 3-hour 100-gram test if the 1 hour is abnormal. Early screening may be completed at 10 to 12 weeks for women with pre-pregnancy obesity or prior history of GDM. Accurate diagnosis via the American Diabetes Association and ACOG diagnostic criteria and timely initiation of treatment has proven to decrease the risk of the outlined maternal and fetal sequelae. Treatment includes education and dietary modification, oral anti-diabetic agents, or insulin, depending on glycemic control needs. Women may be induced at 39 weeks or sooner if clinically indicated. GDM also carries maternal importance beyond pregnancy. The ACOG recommends completion of a fasting glucose level or 75-gram 2-hour glucose tolerance test at 4 to 12 weeks postpartum to evaluate glucose tolerance, on which up to 1/3 of women diagnosed with GDM may demonstrate impaired glucose metabolism. Although for many women this glucose intolerance will self-resolve, studies suggest that women with GDM have a 7-fold increased risk of developing type 2 diabetes compared to women with normal glycemic pregnancies. Black women with a history of GDM have the highest lifetime rate among women of all racial and ethnic groups, independent of age, comorbidities, BMI, or parity. The rate of development is up to 9-fold higher than in age-matched Black women without prior diagnosis of GDM. It is unclear if this stems from something pathophysiologic or socioeconomic. At postpartum visits and at wellness visits thereafter, It is recommended that all women with a history of GDM be counseled on their increased risk for type 2 diabetes, as well as undergo metabolic screening via fasting glucose level or hemoglobin A1C level every 1 to 3 years. Rates of compliance with this postpartum and follow-on screening are low, with Black women being screened at the lowest rates. It is possible that women may develop clinical signs of glucose intolerance later in pregnancy after initial negative GDM screening. Signs include accelerated fetal growth, fetal macrosomia, polyhydramnios, rapid weight gain, polydipsia, polyuria, and glucosuria. However, no specific guidelines currently exist regarding the retesting of women with signs of glucose intolerance after 28 weeks with a previously normal glucose tolerance test. Recent studies, including a 2019 study by DeWitt et al., suggest that among women in this scenario, nearly 1/4 were subsequently diagnosed with GDM on repeat oral glucose tolerance testing and were treated accordingly. This raises concern for a substantial number of undiagnosed women, particularly of higher risk minority groups, who are at risk for GDM-related perinatal complications, as well as lack of identification for future regular metabolic screening and counseling for the remainder of their lives. Given this concern, obstetrical providers should consider repeat tolerance testing when suspicion for glucose intolerance arises later in pregnancy, though there are some issues. No studies yet examine the impact of standardizing repeat tolerance testing. There is also potential for overdiagnosis, increase in or excessive monitoring, undue stress, and increased healthcare utilization for the mother. Additionally, testing and diagnosis later in the third trimester may be lower yield, as late diagnosis may not allow for clinically significant duration of treatment. It can also be argued that diagnosing mild or later onset GDM may not necessarily lead to improved perinatal or lifetime metabolic outcomes. So, should repeat oral glucose tolerance testing be conducted in pregnant women with signs of glucose intolerance later in pregnancy? At this point, further research is needed to establish informed guidelines on this testing, though as family physicians, we should consider repeat tolerance testing on a case-by-case basis given the significant acute and long-term health burden of missing a GDM diagnosis. Here are my references and a few special thank yous. Thank you for your time, and I look forward to a lively discussion.